day, just as I was leaving the office, I decided to pass through just to have a quick one through the ward to see how the babies were doing. And the baby had just been brought in. This was a slightly preterm baby. This child had been referred through 3 facilities before getting to Komfo, deeply jaundiced, badly septic cord, very young parents who had seen the jaundice, and the usual painful story. They had noticed the jaundice. They didn't think it was anything to worry about. The father said, let's wait until tomorrow. If it doesn't get better, we will come to the hospital. But then, as I said, went to one facility, no phototherapy, another facility, finally got to us. We were not able to do the exchange blood transfusion, and another life was lost to newborn jaundice. It's such a tragedy because unlike many of the things that we advocate for, jaundice is relatively easily treated. We know if it's identified early, the treatment is relatively straightforward and relatively simple. And so I think for me that this is one of the most valuable, the most useful campaigns that any pediatrician can make to talk about jaundice, to just tell families that jaundice is dangerous. It's not something that you just look at and ignore. It's something that you must act on, because we know that early treatment saves lives. So I think it's wonderful that May has been set aside as our advocacy for newborn jaundice. The participation has been wonderful, all the videos, people talking, and I hope that next year come May, we will be celebrating the fact that our newborn jaundice deaths have our newborn our losses, deaths, disability has very much reduced. Our early initiation of breastfeeding rates have gone up because early initiation of breastfeeding is such an important tool in the fight against jaundice. So I look forward to next year. I pray that we won't have the same messages over again, that we'll be celebrating the fact that our jaundice is nearly gone, that everybody in Ghana knows about jaundice and knows what to do when they see a jaundice baby. For now, we will continue to talk about it, to share the message, educate families, etc. So on that note, I think that's all I have to say. I hope the program on surgical jaundice will be another excellent one, as have all the programs so far. And thank you very much for your attention. I'm done.
Thank you. Thank you very much, Dr. Mrs. Planjou. And I will say amen to that. We are hoping that come next May, we will be celebrating the drastic reduction in mortality and morbidity from newborn jaundice. So before we move on to our next speaker, a little introduction. His name is Dr. Nicholas Ejay. He's our one and only pediatric enterologist at Komfo Pediatric Unit. And when it comes to jaundice, which is prolonged, he's actually the man to the go-to man. So today we'll hand over to him for him to give us a general overview on the surgical causes of newborn jaundice. Dr. Nico, please, over to you.
Hello, everyone.
Yes, Dr. Nico.
Yeah, good afternoon.
Good afternoon.
Yeah.
Okay.
So just a minute, I will be sharing your slides.
Okay.
Dr. Nico, please, can you see your slides?
Yes, I can see it.
Okay, so over to you.
Okay. Once again, I greet everybody. And today I'm going to present an overview on surgical jaundice. My objective today will be for everyone to be aware of surgical jaundice and to be aware of common causes of neonatal surgical jaundice. And then to also be aware of the importance of early referral of cases of conjugated hyperbilirubinemia. We have surgical jaundice, and it seems like we concentrate so much on unconjugated hyperbilirubinemia, especially not in the big hospitals, especially at anemia. And the normal advice is to put the child in the sun. So we tend to forget about cases that may be amenable to surgery. And therefore, this topic is very important so that we identify the common ones. And then when you are at the district level, if you see any case of jaundice, then you have to determine whether it's conjugated or unconjugated. And then if it is conjugated, then you need to refer the case if you don't have facilities to do further investigations or in case of surgery, to perform the surgery. So this is my aim of this presentation. Can you go to the next slide? Therefore, hello.
We can hear you, Jennifer.
Yeah. Hello. Can, can we share it from here? Hello, Jenfua. Jenfua.
Hello, yeah.
Can we share it from here?
Hello, yeah.
Yeah, okay. So I will start with the definition of neonatal cholestasis, which is a pathological state of the liver, whereby there is reduction in the excretion of bile from the biliary tree into the intestine. So, you know, if you look at bilirubin metabolism, bilirubin is derived from heme and in the reticuloendothelial system, and then is conjugated in the liver and excreted into the bile. And therefore, if there is any reduction in the excretion of bile from the biliary system into the intestine, it will lead to cholestasis, neonatal cholestasis. And neonatal cholestasis syndrome is diagnosed when neonates have jaundice beyond 14 days of age, and is accompanied by dark urine and sometimes pale or chalky white stools. So most of the cases of surgical jaundice, almost all of them, you have dark urine and then pale stools. And anytime you have a child with jaundice, the first thing you need to determine is whether it's conjugated or unconjugated.
Jennifer,
Can we
speaker has
share
been
from here?
muted.
Jemfua, Jemfua, hello. Uh-huh. Let me share from Christy.
Yes, yes, please. Yes,
And
Dr.
we
J,
want
you
to
can
share
start
from here.
sharing.
We want to
Yes,
share.
please
We
start
want to
sharing.
control from here.
Yes, please start sharing.
Okay. So if you look at the biliary tree, we have the right. We have the right hepatic duct and then the left hepatic duct coming together to form the common hepatic duct. Then it will be joined by the cystic duct and to form the common bile duct, which will join the pancreatic duct and the ampulla to excrete bile into the duodenum. So what is surgical jaundice? Is cholestasis amenable to surgical treatment, and it's mainly affects the extrahepatic biliary tree. So if you have biliary atresia and other conditions, they normally affect the extrahepatic biliary tree, and infective metabolic or endocrine causes of neonatal jaundice. And that's the reason why, if you have any case of conjugated hyperbilirubinemia, it's important you refer the case to the specialist to establish whether these conditions are not surgical jaundice. So I would like to present uh, a case that who was referred from peripheral hospital with jaundice, which started in the first week of life. And the child was sent to a nearby clinic during the first week, and the mom was told to put the baby in the sun every morning. There was no feeding for the first 2 weeks. On examination, the infant was jaundice 2 was confirmed. So the labs done, ALP was 600, GGT 400, and then AST 100, ALT 120. Protein was total protein was 62, albumin was 38, INR was 3, PT was 34, and bilirubin was total bilirubin was 300, 435, and direct was 300. So looking at this scenario, you will see that from the total bilirubin is conjugated hyperbilirubinemia. It's more than 50% of the total bilirubin. Scenario. And the other question was, why was the infant referred at the age of 6 weeks? So if you look at this, the child had pale stools and dark urine. What are the things that we have to consider? And it has become a prolonged jaundice because it has gone beyond 2 weeks of age. So this child was referred at the age of 6 weeks. And my question is, what were the possible differential diagnoses? And why was the infant referred at the age of 6 weeks? This is the question I'm asking. And if you look at it, it's lack of information, because the person who saw the mom in the hospital didn't have any knowledge about surgical jaundice, didn't have any knowledge about biliary atresia and all the other causes of pale stools and dark urine. So the only thing the person is aware of is maybe unconjugated hyperbilirubinemia. And if you heard that, you can put the child in the sun. So it was later on that this child was seen at the peripheral hospital, that the child was referred to the our setup. So what now we have to consider the possible differential diagnosis for this particular case. And from what we are going to learn, you will know that when you see a case like this, the first thing you must consider is biliary atresia because of the surgical implications associated with that condition. Then we saw another key, colored stools, was referred from a regional the second week of life, and the abdominal discharge began at the age of 1 month. On examination, he had jaundice and then ascites. And then there was raised GGT and ALP. The bilirubin was 150, and the direct component was 75. INR was 8. So the differential diagnosis in this case uh, is also related to the first scenario data. But here you see that this is a 2 months old with abdominal distension. Biliary atresia, the differential consider biliary atresia consider demonstrated spontaneous of bad that I'll consider maybe choledochrasis. But in this during the second week, and the abdominal distension also, this child came at the biliary atresia causing cirrhosis of the liver. It's possible is that something bad that is not common.
Hello, Dr. J. Hello.
Christy,
Yes, yeah. I
is it from
can't
my
seem to
side
be.
or we lost you, Dr. J?
Okay, so hello, Dr. J. Can you hear any of us? Hello.
Yeah, hello.
Yes. Please. Can you please continue? I think we can't see your screen again. Hello.
Hello, Chrissy.
Yes,
Hello.
Dr. J. Please, would you like
Yeah,
Dr. Jemfua or Pomensa to share your screen? Because we can't see your screen anymore.
can you see our voice? Can you see it?
It's now starting.
Yes, we
Yes, we
can
can
see
now
it.
see.
Okay. So the most likely cause, so the surgical causes of neonatal jaundice, the most common cause is biliary atresia, and it's seen in about 3/4 of all the cases. The second one is choledochratic bowel syndrome, then spontaneous perforation of bowel duct. So that's the reason why we need early diagnosis to prevent complications that may result in into chronic liver disease. You don't need immediate surgery, but there are also causes of neonatal cholestasis, allergic syndrome. You have cystic fibrosis, and then allergic syndrome it affects about 5 systems in the body. And then we have cystic fibrosis, neonatal sclerosing cholangitis, which is also autosomal recessive condition. And then congenital hepatic fibrosis or coloring disease, whereby there is dilatation of bad ducts, at times associated with congenital intrahepatic hypoplasia. So all these cholestasis. So what is biliary atresia? Biliary atresia is characterized by obstruction of the extrahepatic biliary system, which results in obstruction to bowel flow, and is a progressive disease. So it starts from the extrahepatic biliary system and then involves the intrahepatic bile duct. there is a surgical treatment for it, but it's not a definitive treatment, and therefore, when we do it, we need to monitor them over a long time. Normally, it affects neonates of life, because we have different types. We have embryonic type and then the perinatal type. So embryonic type will start early in life, and then perinatal type can start anytime from the second week to the 6 weeks of life. Normally, they are healthy and medical condition. And then surgical correction has to be done before 10 weeks of life. Some people also say 3 months for better results. And any delay in this surgical treatment will cause poorer outcome. And the operation is, we have a child now who is about 12 years, and we have about 4 other children who are also around 2 to 3 years. Then others are below 1 year. They all have the jaundice has resolved. No, there's residual liver disease, but it's mild, and we are monitoring after the surgery may not have any bowel drainage. And 1/3 of this may have severe liver disease associated with it. And in that case, you say the Kazai has failed. Then at times, some of them too may have moderate liver disease. And when you have minimal liver disease, like some of the cases that we have around, then we think that there's a bit of a cure for you. But ultimately, these children may need transport. Area atresia, and increased dramatically in recent years because of improved skills and other things that are added to the management. Then the next at our unit is a rare congenital swelling of the hepatic or bile duct. The incidence is about 1 in 150,000 live births. So far, we have seen 3 cases since we started the GI clinic at CAT, and they are all doing well. They did catheter operation for them. They are all doing well. Recently, one came with and is now fine. So this is can be extrahepatic, intrahepatic, or both. And normally they are due to abnormality in the wall of the bile duct or the pancreatobiliary channel. There may be abnormalities there, and that may lead to choledochrosis. There are 5 types, and I think Dr. Amwa is going to talk about them. That's why I made it very brief. So the surgery that is done for choledochrosis, they do radical excision of the cyst, and then an anastomosis, a loop of intestine to the normal bile duct. The advantages here is prevents malignancy, the incidence of malignancy in later life. Then it's Peter Bowel syndrome. I think we have seen one. The child was diagnosed with biliary atresia. The ultrasound and everything was pointing to biliary, but when they went in, they saw that it's Peter Bowel syndrome. So, and I think they did lavage of the bile ducts, and the child is doing fine. The jaundice resolved, all the liver enzyme returned to normal, and this child is doing very well. So Peter Bowel syndrome is defined as extrahepatic obstruction of the bile duct by bile slide without congenital biliary malformation. So in this case, there are no malformation, there's no problem with bile acid synthesis, and there's no hepatocellular causes of jaundice. And there's incidence is about 175,000 live births, accounting for 8% of all types of surgical jaundice during infancy. and is associated with various conditions such as prematurity, parenteral nutrition, dehydration, hemolytic disease, cystic fibrosis, congenital heart diseases, and then certain antibiotics. Uh, and at times it's difficult to distinguish from biliary atresia, and as it was biliary atresia, but when they went in, it was inspected as syndrome. The patient will be jaundice, have a colic stools, have conjugated hyperbilirubinemia, and no biliary excretion on radionuclear scan. This one I omit it because Dr. Amwa is going to talk about it. Then we have spontaneous perforation of bile ducts. This one is a rare condition, and where bile ducts perforates and bile leaks in the peritoneal cavity. And as I've mentioned, we had a 2 months with spontaneous perforation of bile duct. They normally present with jaundice, abdominal distension, and pale stools, as well as dark urine. And they may have vomiting due to duodenal compression if it's forming a mass and compressing on the duodenum. And biliary ascites may cause inguinal hernias or hydrocele. So laparotomy is mandatory. And usually the bile duct perforation is at the junction of the cystic duct and the common hepatic. And our case, when they did it, that was where the perforation was. The other one we don't talk about is cholelithiasis. I was surprised when I saw a neonate with cholelithiasis. So, and it has a bimodal distribution, which means female predisposition during adolescence. So all types of stones are seen in females. All types of stones are seen in children, but the black pigment stones are more common. That is the calcium bilirubinate. So we have seen 3 cases.
Okay. So sorry about that. I'm sure that at the end of the session, even though we had a lot of breakages in our internet, it's raining in Kumasi, so our network is a bit down. However, I'm sure at the end of this session, we all know that most of the surgical causes of neonatal jaundice is time bound. So whilst you are putting your babies in phototherapy and doing exchange transfusion, at least we should take some time off and then ask questions like whether or not there are pale stools. And then we should also look at their skin whilst they are under the photo, if it's becoming bronze, and then think about a possible surgical cause for that particular patient's newborn jaundice or neonatal jaundice. So thank you very much, Dr. Nico. At least we've learned that when the jaundice is going beyond 14 days, we should think, could this be surgical? So we will move on to our next session. Dr. Nicole was not able to finish. If we have time, he will go back and complete his slides. But we'll move on to our next speaker, who is a pediatric surgeon based in Komfo-Anokye. Dr. Amwa is a surgeon who has his patients at heart, and one of the few surgeons that you can call in the night and he will pick your call and respond to your every clinical need. And his name is Dr. Amwa. So Dr. Amwa, since time is fast spent, please go on with your slides, your presentation. Thank you.
Hello, Dr. Moa.
Hello.
Yes.
Hello, Jaguar.
Hello? Hello?
Hello, Dr. Moa, we can hear you. Please go on with your presentation.
All right, okay. Thank you for this opportunity to join this your meeting. I think it looks like most of the things that I'm going to speak on has already been spoken on already. So without much ado, yes, I'll say that conjugated jaundice arising during infancy may be caused by a number of different surgical conditions, which have been listed down there: biliary atresia, choledochal cyst, inspissated bile syndrome, intrahepatic hypoplasia, Caroli disease, and then spontaneous perforation of the bile duct. Now, you realize that some of the listings are in red ink. Just so that these are the ones that we do see here in Confanoche. The rest, we either find we do not see them, or probably we might have not been able to diagnose, and hence that is why we've not come across any of these. Okay, now this surgical jaundice, I must say, is a challenge to the pediatric surgeon, and the reason is that there's a short time between the onset of the jaundice and the optimal time for surgical intervention. Usually it's recommended that maximum by 8 weeks, the surgery should have been done to avoid any complications that may have a life-threatening consequences on the baby. So what are these conditions? I think biliary atresia, Dr. Nicole has spoken on it. Just that I'll add that yes, it's characterized by inflammatory sclerosing cholangiopathy, which affects the entire biliary tract. It may be either the extrahepatic or the intrahepatic, and this results in obstruction to bile flow, because the bile duct or the biliary tree is replaced by a fibrous tissue without any luminal patency. And it is the most common surgically treatable cause of cholestasis or jaundice during the newborn period, with an incidence between 10 to 15,000 live births. In fact, the most common type of surgical jaundice that we see in the pediatric surgery unit. For the past 5 years, the 19, if you consider the 19 biliary surgeries that have been done, 14 out of them were as a result of biliary atresia. So it tells you that we see that quite often compared to the others. And it's believed to be more common in females and then in Asians. All right. As it's been said already, we have the embryonic or fetal and then the perinatal type, which happens to be the most common in about 65 to 90% of cases. And this usually happens from the second week onwards. The etiology remains largely unknown. But the most widely accepted theory is that there is an unknown exogenous factors that trigger a series of self-limiting inflammatory events in the genetically predisposed individuals during the embryonic or the perinatal period. So these have been found to be probable predisposing factors like viral infections, dysregulation, toxins. Some believe that it's as a result of a defect in the prenatal circulation in the biliary tree, and then also morphogenic defects. Okay, so in taking your history for a patient with jaundice, it's vital that you delve into the perinatal history, the prenatal history, sorry.
Hello, Dr. Amwan.
Yes.
Please, could you put your presentation on slide share?
Oh, okay. Sorry. Okay. Is it okay now?
Yeah, thank you very much.
Yes, thanks.
All right. Okay. All right. So this is the clinical presentation. Whenever you see a child with a prolonged jaundice, usually beyond 2 weeks, and this jaundice tend to be progressive or worsening as compared to others like biliary choledochoccysis, which tend to have sometimes intermittent jaundice. And it's associated with dark urine and pale or ecolic stools, and then pruritus. And one thing is that most of these infants are full term, right? And their appetite and growth and weight gain are more likely to be normal. And so that is something that we shouldn't be dissuaded by, because people might think that because the child looks okay, growing well and all that, and so probably this jaundice is and not pathological, it's just a physiological jaundice, but that's not the case. In terms of examination, your physical findings, hepatomegaly, with the varying consistency of the liver, depending on the duration or the time of presentation. Those who present late may have a hard liver, while those who present the late may have just a firm and palpable liver. The signs of splenomegaly is a main sign, which suggests that probably there is portal hypertension from progressive liver cirrhosis. Okay, some of these patients may have some associated congenital cardiac anomalies, and so it's important that the heart is well examined for any memories. In terms of investigation, yeah, we do the liver function test where you will expect to find a conjugated hyperbilirubinemia of more than 20% of the total bilirubin. Okay, and then there's increased canalicular enzymes, IgGT, and alkaline phosphatase. In late cases, hepatocellular enzymes may also be elevated. And then there's likely to be clotting profile derangement when you check for your INR. In terms of radiologic investigations, ultrasound will show there's the absence of the common bile duct. One thing that people must take notice of is that there would not be intrahepatic biliary dilatation, because some people think that because of the obstruction, there should be dilatation of the biliary, intrahepatic biliary system, but this is not what is found, because the condition is fibrotic, and as such, the entire biliary tree becomes fibrotic, and as such will not be become dilated. But what we found the ultrasound is a ghost triad, and then the triangular cord sign. And when these are found, it tells you that you are dealing with biliary atresia. We can also do radioisotope imaging using the technetium labeled immunodiacetic acid. And this actually is not a confirmatory test. It only rules out the possibility of biliary atresia, in the sense that once the test is done and you see secretion of the isotopes into the duodenum, then it tells you that there's no biliary system obstruction, and therefore biliary atresia is out. but the non-secretion of the isotope does not confirm the presence of biliary atresia. In fact, it's even believed that high levels of conjugated bilirubinemia may even prevent the uptake of the isotope. And so in some instances, people may administer certain medication that will enhance i.e. phenobarbital to enhance the uptake of the isotope by the liver. And then biopsy, and then laparoscopy or laparotomy by visual view is a confirmatory diagnosis for this condition. Once you see that the biliary system is athletic, then confirms it, and then you take a biopsy, which will also give you the histological indices for that. The treatment is for surgery, but before the surgery is done, these things must be done. The coagulopathy must be corrected to make sure that your INR is within range. If there's anemia, that has to be corrected by hemotransfusion. The child must be adequately hydrated, because dehydration can cause what is known as a hepatorenal syndrome. It's believed that the bile pigments can cause damage to the kidney, resulting in acute kidney injury. And then the hydration fluid must contain some amount of dextrose to boost up the glucose reserves of the patient. And then prophylactic antibiotics should be given. The interim treatment is casaepatoenterostomy, which originated from this man, Professor Mario Casar, in 1959. And I must say that from the 1840s, when Ladd attempted a surgery for biliary atresia and failed, between that time until 1959, that period has been classified as the dark ages of biliary atresia, because there was no remedy for these patients. And then post-op nutritional support, and then medication to stimulate choleresis, like also deoxycholic acid, and steroids are given to enhance bile secretion. And then antibiotics are given to prevent infection, especially within the first 2 weeks. Is very critical for the sustenance of secretions with the surgery, in the sense that these patients are predisposed to ascending cholangitis. And because of the already existing condition that they have, which is fibrotic in nature, any inflammatory condition will worsen the fibrosis and hence cause failure of the bypass that has been done. All right, so these are the possible late complications of the condition: bile acids accumulation causing pruritus, and then xanthomas from cholesterol accumulation, and then hepatotoxicity. In the GIT, there will be malabsorption of certain vitamins, the fat-soluble vitamins, and then they will have Ecolex-2 and then steatorrhea, which may result in malnutrition. We found that these patients are likely to have delayed neuropsychomotor development. The cholestasis eventually will cause progressive liver disease, resulting in cirrhosis, portal hypertension, and then eventually liver failure. The prognosis largely depends on certain factors. The key amongst them are what have been highlighted in red: the timing of the surgery. The earlier, the better, and it's preferable if it's done within 8 weeks. In some of the literature, you'll come across extension to 90 days, but I think the earlier, the better. Let me leave it to be. It has to be done before the liver becomes fibrotic. Otherwise, after the surgery, there wouldn't be any achievement of bile drain. Okay, and then also the experience of the surgeon and the surgical approach used, and then the use of adjuvant medications to enhance the secretion of bile. And then recurrent cholangitis, which has been found to be a poor indicator. And as such, it has to be managed aggressively whenever it's suspected. The next one is choledochal cysts. That is the next common condition that we see here. 5 out of the 19 surgeries were choledochal cysts. This is characterized by a varying degree of congenital cystic dilatation of the biliary system, and it can involve both the intra and extra hepatic radicals. Okay. And it may be a single or multiple cyst. The incidence, I think Dr. Nicholas has already made mention of some of these, so I may have to skip and then, all right. But just to say that about 80% of them are diagnosed within the first decade of life. Okay, so in terms of etiology, there has not been any unified etiologic factor for this condition. But it's been realized that it's probably from multifactorial reasons. The most common or the most plausible explanation is a anomalous pancreaticobiliary duct union, which has been found in 30 to 70% of patients with this condition. And this is a situation where, under normal circumstances, the pancreatic duct should join the common bile duct at less than 1 cm before it join the ampulla of Vater. But in these children, the pancreatic duct joins the common bile duct at a distance more than 1 cm from that. And this creates a situation where it allows the reflux of pancreatic juice into the biliary system, which will cause the digestion of the biliary tree and the weakness, resulting in dilatation of the biliary tree to give the cystic situation. All right, so there are several classifications, but the most widely accepted one currently now is the Todani classification, which classifies the conditions into 5, as depicted by this picture. The clinical presentation is that these patients can present or they can manifest symptoms at any time, even beyond the neonatal period. There's that 80% of them, as I've said, are diagnosed within the first decade of life, and they have a classic triad of abdominal pain with the right upper quadrant mass and intermittent obstructive jaundice, unlike biliary atresia, which has a progressive or worsening jaundice. In this patient, the jaundice may be intermittent, on and off. So when you see a baby or a child with this kind of jaundice, you should suspect choledochal cyst. Some of them may exhibit symptoms of cholangitis or pancreatitis, as well as portal hypertension, right? And then liver function tests usually will give you some abnormal findings of elevated liver enzymes. But in addition to this, the serum amylase and lipase concentration may also be raised, which will give an indication of pancreatitis or cholangitis. And because most of these patients may be presenting with vomiting, especially when they get the cholangitis or pancreatitis, sometimes their electrolyte, the serum electrolytes may be deranged as well. And then WBC count will also be elevated with more of the immature forms. Imaging, several imaging modalities can be used. The most common one which we use here is the ultrasound, which will show you the dilatation of the extrahepatic biliary or sometimes the intrahepatic biliary system. But a CT scan, MRI, and the others can. But the most, the gold standard is the MRCP, which will give you a clear picture and then also give you a topographical relations of the cyst to the surrounding structures. So this is an intra-op picture of a choledochal cyst, and then after the cyst has been resected. All right, the next is the inspissated bile syndrome. This is a situation where you have bile ducts being obstructed by impassion of thick bile plug during the neonatal period. It's one of the rare causes of surgical jaundice in the neonate, and the etiology is of heterogeneous sources. Majority of these patients will require intervention, either radiological or surgical, but the long-term outlook is quite excellent. Our the etiology includes the listed causes here: prematurity, cystic fibrosis, starvation, TPN, dehydration, some drugs. Okay, but about 43% of such cases are idiopathic, and no investigation will reveal any underlying cause for that. They present with jaundice, dark urine, and ecolic stools, like any obstructive jaundice. So in terms of investigation, ultrasound would either show mild to moderate biliary tree dilatation and a sledge of stools within the common bile duct. But there are times that you may not see this. And then a radionuclide isotope scan will show hepatic concentration of the isotope without any excretion into the duodenum. So as I said earlier, with regards to biliary atresia, the non-secretion of the isotope does not give a confirmatory diagnosis, because it only shows that there's just obstruction to the biliary tree and nothing else. Okay. Then biochemistry will show deranged liver enzymes with predominant conjugated hyperbilirubinemia, and also elevation of the canalicular enzymes, alkaline phosphatase, and the gamma glutamate sulfates. Laparoscopy in a well-resourced center can be done, and this will serve as both diagnostic and therapeutic purposes, in that the laparoscopy, it will be found that the biliary, extrahepatic biliary tree is well developed, and the gallbladder may be dilated with bile. The management, some may be amenable to just hydration, just adequate hydration will clear the sludge, and then the bile will start flowing and the jaundice will start clearing. Sometimes the use of ursodeoxycholic acid may be needed to enhance bile flow, to enhance the ileohepatic circulation of bile. And then cholangiogram with irrigation sometimes may be needed. It may be done percutaneously or sometimes through laparoscopy or laparotomy. This is a picture, an intraop picture of such a case that we did. And you can see that a cannula has been inserted into the gallbladder and the system is being flushed with saline. And this shows the picture before and after the surgery, where before you see obstruction, which is indicated by the white arrow, and then there's a dilatation of the proximal biliary tree, and then post irrigation, you can see that the dilatation has resolved and there's excretion of the contrast into the duodenum. And then we have spontaneous perforation of the bile duct. This is a rare condition and usually occurs between 2 weeks to 20 weeks. There's no clear etiology for this as well. However, 3 potential etiologies have been proposed. And one is biliary wall weakness due to ischemia, abnormal pancreaticobiliary union, and then there's also the belief that it's one of the extreme ends of choledochal cyst. So this picture shows an intra-op where there was a perforation of the common bile duct. Okay, it occurs at the junction between the cystic and the common bile duct. That's where the perforation. And these patients present with acute deterioration or distress right from birth, but occasionally some of them may have an indolent presentation. And it is very important that a prompt diagnosis is made for optimal management because they can deteriorate very fast with development of sepsis within a few hours to days. Okay. Now the deception here is that sometimes some of them may have a very healthy interval from birth up to the time of clinical presentation. Just that they will have the jaundice, but everything will look all right, as if it's just a physiological jaundice. And so one has to watch carefully and assess the patient well. So they will present with jaundice, abdominal distension, ascites, and then sometimes normal or ecolic stools, dark urine, evidence of peritonitis, right? Some may even present in shock. So whenever you see these patients with obstructive jaundice in association with signs of peritonitis, then one should look carefully for spontaneous perforation of the bile duct. In terms of investigation, biochemistry will show elevated hepatocellular enzymes. On the ultrasound, there will be ascites, or sometimes it may be just a biloma, collection of the bile within the subhepatic space. And that might sometimes be interpreted as intra-abdominal abscess. Sometimes there may be ductal dilatation and then at times fluid collection in the entire abdomen. HIDA scan or radioisotope scan may show extravasation of the isotope into the entire peritoneum, and that will tell you that there's a leakage of bile into the peritoneum. In recent times, MRCP has been more popular and been as the diagnostic. The treatment is somehow surgical and somehow may be conservative. Just irrigation and putting in a drain sometimes may resolve. But at times you be the need perforation, or you may do So in terms of assessing the infant with the jaundice, this is an algorithm that I found. You start with your history the history should be meticulous and detailed. Okay, asking for when the jaundice was noticed, and then the other associated symptoms. If the jaundice came or was noticed after 2 weeks of age, then it's abnormal. Physiological jaundice will not go beyond this period, and therefore once it goes beyond 2 weeks, there's a need for a thorough investigation of the neonate. Okay, and then the history should also include the antenatal history, events that happened during the pregnancy, medications taken, and then as well as vaccination history. And then physical examination should not be limited to just the GIT, but the entire child as a whole. Your GIT examination should not go without a digital rectal examination, because under no circumstance should the pills to be missed, right? If the child has not passed tools, you have to do digital rectal examination and look at this, the nature of the stools that will stay in your examining finger, or you may ask the mother to keep the stools for inspection later on. I remember I've seen Nicole collecting stools and even incising them to see the core, how the core of the stool looks like. So I think all this must be done if we are to assess and to diagnose surgical jaundice promptly for management. The other investigations must be done, and then depending on what the finding is, one may come out with the appropriate diagnosis of the condition. Okay. I'll end by saying that surgical jaundice in the neonate is an enigma with a variety of underlying and life-threatening diseases, as have been listed earlier on. Because we can't actually pinpoint what is causing what. It may be from any of these conditions. Okay, and though the clinical picture of some of these conditions are obvious, some may have a more subtle presentation, and that necessitates a high index of suspicion for diagnosis. A timely management is required for an optimal outcome, because as I've said, this is one of the challenges that we face in surgery. Most of the times, by the time you see the patient, the child will be over 8 weeks, and your surgery will be hanging as to whether you achieve what you seek for in your surgery or not. One key thing that we should take note of is that not every neonatal jaundice is literally afraid of the early morning sun. There are some who become more angry with that. And so it's not every neonatal jaundice that will require the early morning sun or phototherapy for treatment. And so clinical vigilance and prompt investigations are key if we are to pick up these conditions early for prompt management. Okay, and then so when you find jaundice beyond 2 weeks, there's a need for a meticulous investigation to come out with the diagnosis and management, as a delay in surgical treatment may only result in progressive liver damage and liver failure. So a timely intervention can save a great deal of liver damage. And then I must say that certain cultural practices must be stopped, in the sense that you realize that once a baby, a newborn is sent home, is kept in an enclosed room, the windows are closed, curtains are drawn, and so the room becomes not well lit enough for the jaundice to be detected if it is present. And so I think these are some of the practices that as a healthcare practitioner who deals with children should educate the mothers from some of these practices so that what be detected early and be sent to the hospital for appropriate management. On the part of the practitioners, but I came across an article where people use the distribution of the jaundice to detect as to whether there's a need to investigate or not. The belief is that the jaundice usually will start from the face and descend down. And so to some people, unless the jaundice crosses the umbilicus, it's still safe and there's no need for investigation. But the fact is that detection of jaundice in the black skin is not as easy as in the white skin, okay? And therefore, I think I should have made mention of this. In examining the child, it should be done in a well-lit or well-illuminated setting so that we can see clearly. And if there's any jaundice, yes, it will be detected and then the appropriate management be instituted. Thank you.
Thank you very much, Dr. Amwa. Indeed, you couldn't have said it any better. This facet of newborn jaundice, surgical causes, may be an enigma, but we can all demystify it through meticulous clinical vigilance, as well as following up with the right investigation so that we can make the right diagnosis and then put in place the right interventions. Throughout all the presentations we've had, time seems to be of essence when it comes to the surgical causes of newborn jaundice. So today we've learned that when the jaundice is becoming prolonged, when it's going beyond 2 weeks, we should think of a possible surgical cause, take a thorough history examine, and then maybe call the surgeons in if we think it could be a surgical cause. So at this point, we are ready for your questions. Both speakers, Dr. Nicole Lasejay and Dr. Amwa, are on standby to take your questions. Or you can type your questions in the chat and I'll read it. Suggestions are equally welcomed. So from one of our participants, I think this question goes to either Dr. Nicola Sejay or Dr. Amwa. What percentage of your biliary atresia patients have other abnormalities such as a congenital heart disease? And this is from Dr. Ajiman. Please, any of the panel speakers can take the question and answer.
Okay, thank you. From my experience, I think that is on the low side. I'll put it to about 5 to 10%. Most of the ones that we do are those who come with just isolated biliary or what is known as the non-syndromic type of the biliary atresia. Yeah, I think I can count just about 2 or 3 cases where they had situs inversus and then polysplenia. Yeah.
Thank you very much, Dr. Amwa. I hope your question has been answered, Dr. Jiman. This is yes, Dr. Nico, please go ahead.
Yeah, and I think we have seen about 5. 3 of them were operated, and then two had this situs inversus totalis with dextrocardia and complex heart disease, complex heart malformation. So presently we have one child with situs inversus, dextrocardia, heart Kazai. So that is the embryonic type of biliary atresia. So we have one now that we are, and I think two. We have two, one in Graham and then another one in Ashanti region.
So Dr. Ajiman, I hope you are okay now. So this is also a question and I think a comment from Dr. Mrs. Jekwa Planjou. We often see conjugated hyperbilirubinemia after exchange blood transfusion. So it's a question. How long is it safe to wait to recheck, or should we be concerned as soon as we identify it? We often see conjugated hyperbilirubinemia after exchange blood transfusions. How long is it safe to wait to recheck, or should we be concerned as soon as we identify it? Please, Dr. Nico and Dr. Amwa. I think either of you can take this question up.
Yeah. Hello, Jeffua.
Yes, Dr. Nico.
Yeah, I've seen a lot post exchange transfusion. What I do is normally I monitor them, and almost all of them the jaundice resolved, the conjugated hyperbilirubinemia resolved. So normally after the exchange, once I detect it, I monitor them, and almost all of them the jaundice resolved.
Okay. She was asking if it's actually quite safe to wait to recheck. So I think from your answer, it's quite safe to wait and then recheck.
Yes.
Okay.
Yes, if what I would add is yes, once you see it, you must investigate to rule out any obstruction in the biliary tree. Once that has been ruled out, then you can wait, and then also provided you are sure that I know that calves, of course, the blood we transfuse are safe. Right now, as I say, you must be sure that the blood you transfuse is safe. Maybe no element of hepatitis or whatever, because that can also give such a picture. Okay, but once these are ruled out, then you can just monitor, and usually between 2 to 6 weeks, it should clear that conjugated hyperbilirubinemia should resolve.
Please, Dr. Mrs. Planjou, are we okay? Has your question been answered, ma'am?
Sorry, I hope you can hear me. I'm in a bit of a noisy place, but the answer seems to be conflicting because Dr. J seems to be suggesting that you monitor until it resolves, and Dr. Amwa said investigate immediately and rule out surgical causes. So if they could reconcile the answers. It's something that we see quite often, and we're not always very sure how to proceed after the exchange.
If I don't think we are. What I'm saying is that once you've ruled out the possibility of any form of obstruction, then you can monitor, because you cannot always say that or be sure that the obstructive jaundice the patient is having, or the conjugated hyperbilirubinemia the patient is having, is merely because of the exchange transfusion. For him, it's just a coincidence. And therefore, that's why I'm saying that once you rule out any possibility of obstruction, then you can monitor. And as I said, we've seen instances where even hepatitis at times can cause that, especially idiopathic neonatal hepatitis is one of the causes of obstructive jaundice in neonates. And so that's why I'm saying that all these must be ruled out. And once they've been ruled out, then you can monitor. Because if you are in a setting where you can't be sure whether the blood you are giving fine. I know Confaloche, as I said, we screen the blood, and therefore, I don't expect that we will be transfusing any Hep B contaminated blood to any baby.
Okay. Okay. Thank you very much. I hope we are good to go. I guess.
Yeah.
Hello, Dr. Nico.
Yeah, it's when I say monitoring, it's not just by monitoring the levels of bilirubin and then the direct. We
Okay.
also investigate for other conditions because it may be
Okay.
coincidental, just as Dr. Amwa said. So normally, when I say monitoring, we do other basic ones to see whether there is any associated condition. Maybe initially everybody thought is unconjugated hyperbilirubinemia, and then exchange transfusion was done. So when I detect that is now conjugated hyperbilirubinemia, investigation and then follow up the patients to make sure that it's not due to any other condition.
Okay. Thank you very much, Dr. Nicholas and Dr. Amwa. Please, Dr. Jackie, you may speak. You can actually ask your question. Yes.
Thank you very much, Dr. Jimfua. I want to ask about neonatal hepatitis syndrome. It's not a surgical cause, but since we are lucky to have Dr. Nicholas here, could he just summarize how we should manage neonatal hepatitis syndrome? Because it's also a very common cause of prolonged and conjugated hyperbilirubinemia. We see a lot. Thank you very much.
Okay. Dr. Nicholas Ajay. Dr. Nico.
By itself, it's a syndrome, and what we are considering is that maybe there are certain things that you are supposed to do and you can't do them. So you put all together and say idiopathic neonatal syndrome. One, you have to make sure is diagnosis of exclusion. So you need to investigate for other conditions. Then when you have excluded other conditions and then you are limited, then you attribute it to neonatal hepatitis syndrome. So that is how I view it. And most of the cases we say, oh, idiopathic neonatal hepatitis syndrome, because there are other things we can do. You have done all the basic things that we need to do. And then with our limited resources, the possible things that you have to do, you have done them. And you can't diagnose anything. So then you put them together and follow them up. Some of them may survive, others too may progress to liver disease. And then so idiopathic neonatal syndrome, if you are in the district level and you can't do certain investigation, it's better you refer. Don't just say idiopathic neonatal syndrome and follow them up. You have to refer to a bigger hospital where maybe if you have anybody to do further investigation to find out what is actually causing it. Because most of the idiopathic neonatal syndrome, some of them may present with pastules. So initially you may think it's maybe biliary atresia, and then when you investigate, you find out that it's not biliary atresia. Then you need to do other investigation, maybe the torches, maybe the galactosemias and the rest. So once you have ruled all of them, and probably you've done your liver biopsy, then you can just say, and if it's neonatal, there are specific findings you may see on liver biopsy, and therefore you can then attribute it to idiopathic neonatal syndrome. So once you are not sure, it's diagnosis of exclusion, refer.
Thank you very much, Dr. Nicholas. Dr. Amwa, please, your hand is up. Would you want to comment on this?
No, I just want to find out something. Nico, over here, do you do genetic studies for some of these neonatal jaundice?
No. We don't. Yes, there's only one child, and even that one, the child was sent outside, and they did the genetic studies to confirm it. And then the child was sent outside, and they did the genetic studies to confirm it. So here we are limited, but once there are basic ones that we can do, and I think we are doing well with the small investigations that we can do.
Okay.
Dr. Jacqueline, I hope you are okay now.
Yes,
Okay,
please. Thank you very much.
You're welcome. Please, there was another comment by a panelist. They wanted to know, I think from Irene and then Madam Charlotte Sampson. They wanted to know why it's termed surgical jaundice. I mean, I think for surgical jaundice, it typically refers to the surgical causes of neonatal jaundice or newborn jaundice. Please, Dr. Amwa and Dr. Nicholas Ejay.
Yes, it's called surgical jaundice simply because the management requires surgery, right? That is why we termed the surgical jaundice, because the management will require surgery of a sort to be done, and that is why it's called surgical jaundice.
Okay.
Okay.
Thank you very much, Dr. Amwa. Okay, please, are there any more questions, any suggestions, any comments? Okay. In the absence of any comments or questions, I think we are about coming to the end of today's meeting on the surgical causes of newborn jaundice. Dr. Mrs. Planjou, since you gave us the opening remarks, would you be kind to give us the closing remarks as well?
Sorry, Jennifer, was that to me? I'm sorry.
Yes, please. Was wondering if
Oh,
you give us
sorry. I'm so sorry.
the closing
Yeah.
remarks.
Yes. Yes. So thank you very much to Dr. J and to Dr. Amwa. Those were two really good presentations. I think it's important to keep in mind that not all cases of jaundice need to be put under phototherapy. And I think this is important. You sometimes see children who are 2-3 weeks old who have been kept under phototherapy for the whole period and are finally referred. And obviously this delays the treatment. And so I think it's very important as pediatricians, as people who work with children, that we recognize that outside the world of unconjugated hyperbilirubinemia, which we know can lead to brain damage, there are also surgical causes, and which also need urgent attention. And it's important that we develop the clinical acumen to be able to distinguish between the two different types. So a very big thank you to our two presenters. Thank you very much. We really enjoyed your session. Thank you.
Thank you very much, Dr. Mrs. Planjou. Okay, so as I said, we've come to our session. Thank you to Dr. Nicholas Ejay. Thank you once again to Dr. Michael Amwa. Now we know that for some types of jaundice, the answer is not only phototherapy or exchange transfusion. You may need a surgeon. Thank you. So I'll just share a quick prayer and then we will close. Our Father in heaven, we thank you for giving us a great session like this. We thank you for the knowledge that has been impacted on all the people who participated in this meeting. We pray and ask that you, Lord, will help us use this knowledge in our practice to help babies who come into contact with us, babies who have newborn jaundice. In Jesus' mighty name, we pray with thanksgiving. Amen. So thank you, everyone, for your audience. Have a good evening. Bye-bye.
Bye. Thank you.
Bye.
Bye.
Bye.